And the topics for me this morning was to talk about some suggestion and some helping points for the patients to do in a best way how to manage the time for high-risk clearance techniques. And I think it's a very, very big question, because every one of us knows that high-risk clearance techniques is one of the most time-spending and strength-spending part of the cure for PCD, for cystic fibrosis patients, and in a lot of other chronic respiratory disease, such as neuromuscular disease, and a lot of. So it is a very, very big question to talk about, because we have, until now, we have not many information from the evidence, from the research, to choose on the times and to choose. So I will try to. Why we do high-risk clearance techniques? We do high-risk clearance techniques, first of all, to improve the quality of life of our patients. But inside the box, we would like to maintain lung function and reduce disease progression. This is true for PCD, is true for cystic fibrosis, is true also for neuromuscular disease. We have a lot of experience about what is the job of our clearance techniques. It's a very easy job. The job is to manipulate flows, deep inspiration, deep expiration, short expiration, cough, forced expiration techniques. And we have a lot of proof of concept data about the physiology of high-risk clearance techniques. And we know that a lot of works that we do, a lot of devices that we use, such as oscillatory positive expiratory pressures devices, high frequency chest compression, makes a precious, a specific physiological work in our airways. And we know that we have a strategy, a global strategy of high-risk clearance techniques. We have to open our airways, we have to move our mucus toward the mouth. And we do regularly in our practice, once a day, twice a day, sometimes thrice a day. And sometimes I feel some noises. Okay. And also more. We know that every device, every techniques can be specific for some parts of our lungs. And we know that we can act in specific areas of our lungs. But when I want to choose a techniques on the other, when I want to talk about specific times, we have no data. Really, we have no data. So we can just talk about suggestions. We know that some techniques are most effectively done for little child. Other techniques needs more cooperation. So we can start to do a little specification. So now we have some evidences, but a lot of possibilities to, in a problem-solving manners, to choose the way how to do our high-risk clearance techniques. We know that ACT, and for this we have a lot of papers, of scientific papers that say us ACT poses us a lot of problems about barriers and burdens for the times. So what is our work? Our work is to try every time at every contact with our patient to balance the problems about correct techniques and incorrect techniques. For example, for positive expiratory pressure mask, we know exactly what is the disease, but we have to know that PEP mask is not the treatment. PEP mask is composed from two domains that are a domains of quantity, a domains of quality. On the domains of quality, we can do a big work, and this is a must for the physiotherapist to go out from comfort zone, to go to work on the right pressure, to go to work on the right way to do expiration. In this way, we can try to balance about the quantity and the quality. And if the clinical scenario of our patients permits, we can try to go to make a more specific iris clearance techniques, trying to reduce the part of the treatment that we cannot, we think it's not necessary in the moment for that patients. So quality and quantity, some practical points could be: look at our devices for nebulization. Good, well-maintained equipment could be, and I think that sure could be, less time to inhalation time, a good technique of inhalation, proper breathing, a proper use of bronchodilator, and try to erase the drugs that we know are not useful for our child and for our patients. So the work that we have to do every day with our patients, and every day physio is listen and talk about and build at every check visit clinic the program of our patients. Try to have a common and shared strategy in the looking at the lifestyle of the patients, and talk about the problem, verify and measure what's happening when we are trying to change iris clearance techniques in the means of times, in the means of frequency. And not last, try to have a good feedback of the black box. The black box is, to me, it's what happened in the real life, what happened at the home of our patients, and that can give us a lot of good information to try to build a good iris clearance techniques in real life. Thank you very much.
Thank you. I would like to now invite Kremer, who is a physiotherapist since 90s. His main field of activity is lung and heart rehabilitation in adults. He lives in Germany near the Dutch border and works in the Netherlands. He has two daughters. The older one has PCD and she was diagnosed at the age of 9. Kremer, he has been a member of the board of the German PCD support group. Welcome.
Thank you. When we talk about physical activity, we should start to train when our exercise capacity is too slow, too weak, when our muscles are too weak, when our inspiratory muscles are not strong enough. This is important for all people, but in PCD is extra. I don't know. Yeah, it's okay. It's very clear that we all have to be fit and as fit as possible. All the people with PCD, they have got it from genetic failure. You're not responsible for your disease, but I think you're responsible how you manage your disease. It's not your doctor, it's not your physiotherapist, and just with small children, the parents are important. But when you get older, it's your responsibility how you manage your airway clearance techniques, how you manage your sport, your physical activities. Next slide, please. Why should we have a good physical activity or our condition? A stronger and better condition gives you less breathlessness, less dyspnea, more social contacts. You can go to sports, you can go to school, you can go to work for your self-reliance. And after all, it gives you more quality of life. Next slide, please. There are several ways to test your condition on a bike. You can test your muscle strength with certain, I don't know the word. There are all values, norm values, so you can check if your fitness isn't good enough, then you should start to train. Next slide, please. How do we train? The most important thing is by training to do something that you like. When you like running, when you like walking, when you like swimming, when you like to go in a fitness center, then you manage to hold on. While it is one very important rule, use it or lose it. And you only can hold the effect of your moving or your fitness training when you do something you like. You've got to train the rest of your life. Next slide, please. In the Netherlands, the government has a goal for every person. Every person should at least move or do moderate exercise at least 5 times a week for 30 minutes. And for elderly people over 70, they should 2 times a week do strength training. And for example, COPD patients, 16% move or exercise less than 30 minutes a week. And that is how do PCD patients do. What they do, we don't know. But you should be as so active as possible. It's got a good relation on blood pressure, mortality, cardiovascular disease, adult onset diabetes, quality of life. Next slide, please. Here's another point I want to tell you. A lot of patients have problem with dynamic hyperinflation. When they do exercise, we inhale, but we can't exhale enough. So we start to breathe higher, and that gives a dyspnea. A good trick to manage dyspnea is to use pursed lip breathing. You can do it when you're walking stairs, when you do sports. And when you elderly people who have difficulties to walk, they can use a rollator. I don't know if it's English, but you can lean forward. When you lean forward, you can use your muscles in the shoulder to breathe. Next slide, please. Here you can say on the slide, on the first slide, the pressure in the thorax is very high, so the airways can collapse. When you use pursed lip breathing, the airways get open. You can easier breathe, and you get less dyspnea. Next slide, please. Now, Paolo and I can answer.
We are super happy to be here.
Yes.
Thank you for having us.
It feels a little bit like a dynamic duo of Muppets. That's probably how we are in clinic as well. All right,
That's
go ahead.
right.
So Tammy's going to lead us off here with some background and context about how we like to think about mental health and PCD in our center and why we feel it's so important that that's integrated into PCD care through your center.
Okay, so I'm going to move to our learning objectives here. You can switch for me. Slides.
Yep.
Thank you. So we're going to talk about the prevalence of mental health issues associated with chronic medical conditions, and then review the common mental health issues related to PCD, tips for building resilience and coping with PCD, some wellness and protective factors, and then we're going to talk about how to integrate mental health care in the PCD care model and kind of how we do that in our clinic. So first, the prevalence of mental health issues. So we know chronic medical illness is a risk factor for psychiatric disorders. So this is widely seen in the literature. It's shown in patients with cystic fibrosis, asthma, diabetes, inflammatory bowel disease, and this leads to elevated levels of stress, anxiety, depression, especially found in patients with multiple chronic diseases. Comorbidity is associated with negative health outcomes, so such as poor treatment adherence, increase of healthcare utilization, a lower BMI, decreased lung function, and impaired quality of life. And there's also associations between caregiver mental health and exacerbation in children. This is seen in the CF literature a lot, where parents with anxiety and depression also have adolescents with elevations in anxiety and depression. The highest anxiety and depression found in mothers, actually. And a study out of Italy in 2013 showed mothers of PCD patients reporting higher levels of stress compared to the control. There are limited studies, though, that have shown the psychosocial impact in PCD. There's a few that reflect the need for some ongoing research and support in this area, definitely. And there's been a couple most recently in 2021 out of Amsterdam. Dutch patients with PCD and their caregivers had elevated levels of anxiety and depression, which were associated with worse quality of life. In 2020 out of Spain, they talked about psychological well-being in adolescents. So there's been a few that really highlight this need, but much more work needs to be done in this area. Next slide. So looking at the common issues in PCD that impact mental health, this slide might feel a little overwhelming. But I think it's a good reflection of what we hear so many of our patients deal with every day. So most common stressors I hear when meeting with families that impact wellness, you'll see on this slide, and everyone's PCD journey is different. So for some parents, there's the initial grief and the guilt at time of diagnosis, in addition to the ongoing fear and the worry of a child's future. While other families are coming to the diagnosis much later in life and relieved to finally have an answer to the symptoms that they've been managing for so long, and they now have a plan for treatment. So we know the journey to PCD is different for everyone. And then the stressors in managing the disease for both patients and caregivers and adults include coordinating care and the appointments, managing the treatment burden, just the disease progression, exposure to medical trauma, sleep issues. I mean, this list could go on and on. You guys know this better than I do. And you could probably add so many things to this list. And so we highlight this because it's so important to acknowledge how chronic health impacts mental health and all that you have to manage. So going into it a little bit further, we're going to look at anxiety and depression. Given the previous slide, we know that there's additional complexities to PCD, right? But how do you know when you have a more significant concern? So we're going to look at anxiety and depression and kind of tease out the normative stressors from the more concerning issues. So looking at anxiety in the setting of life changes, are they temporary or persistent? So temporary anxiety related to life stages, such as a recent move, going to college, a new job, or for kids, periods of development, right? Can be situational. They're appropriate to the current stressor, like a presentation or an exam. These stressors are temporary and passing, versus anxiety that does not seem related to a current stressor or a situation and is really persistent. And it can lead to an inability to really control that worry, hypervigilance, or trouble concentrating. Looking at social behaviors, is it kind of personality temperament or a change in typical behavior? So many people fall on the spectrum of being introverted, shy, or have a personality where they're maybe slower to integrate in social situations. And this can all be really normal, part of personality, versus a change in behavior or a new avoidance of social situations. So kids that don't want to go to school, or you're having a hard time going to work, or you don't want to go out and see friends like you used to. So when this behavior is not typical for that person and is a change in performance, either at school or work, that's more concerning. Expression of worries, is it situational or persistent? So some worry and fear can be expected and really appropriate. It's okay to express worry about your PCD illness from time to time. So when you're having increased symptoms, when you have fear of your future, Even kids stating they wish they didn't have PCD. It's good to express these feelings because you can seek support and you can seek ways to cope and reduce that stress and worry versus expressing persistent and impending doom or panic or danger that really leads to avoidance. So you have so much worry that you're now avoiding doctor appointments or you're avoiding those medical treatments or you're starting to suppress your cough. Things are just too triggering. And when you're unable to cope with a worry, that can impact your daily functioning and your ability to engage in usual activities. And then somatic symptoms. So are they temporary or persistent? Things like fatigue, stomach ache, sleep disturbance. These can be really normal in situational stressors or times of illness, and then they subside, versus persistent symptoms with no other real known cause. Similarly, when we look at depression, thank you. Changes in mood or behavior, again, kind of the context of is it temporary or persistent? So changes due to a situational factor, such as grief or loss, a toxic work environment, or developmental milestones and transitions in kids, like a new school or a change in the family system. All of these are temporary and can be really appropriate until that adjustment stabilizes, versus a change in mood that is persistent across situations and contexts. Looking at somatic symptoms, interrupted sleep, fatigue, low appetite associated with a situation that would be normal for that, like a PCD cough or illness, can impact somatic symptoms, change in schedules, versus a change in sleep, appetite, or weight that's associated with a low mood and really persistent across situations. And one thing to highlight, since we do work in the peds population, we know that kids verbalize physical symptoms first when it comes to most mood-related issues. So they may not tell you about a breakup or a difficulty navigating a friendship dynamic at school. They might say, I've had this stomach ache for a week or a headache that just won't go away. Looking at social behaviors, is it fluctuations in motivation or a persistent decrease in engagement? So fluctuations in motivation to attend events, engage in social situations, treatments, or even cooperate with your PCD care can be really normal, versus a persistent decrease in engagement or the ability to maintain expectations and routine. So to keep up with treatments or difficulty going to school and work, a real drop in performance. And then expression of sadness or anger is expected and situational, or a persistent feeling of hopelessness. So experiencing sadness, frustration, anger is normal when it's appropriate to the situation. So even having anger about having PCD, wishing you weren't born with PCD. We hear this from kids, and you're allowed to feel this way, and it's good to express this. You can name this and you can cope, right? Versus excessive guilt and hopelessness, a desire to die, thoughts of self-harm. You've really lost the ability to cope. And younger kids also express more persistent irritability versus sadness. So kind of being able to tease out some of those emotions. So when do we seek help? So we really, I mean, especially given that poll we just took, is saddening to me. I think therapy is for everyone at any time. So I don't think you have to wait until you're in a crisis or have severe concerns to seek support. We all benefit from learning about ourselves and finding ways to cope and communicate more effectively and prioritize our self-care and wellness. So we think that preventative mental health care is really key. But given those previous slides, definitely seek support if what we reviewed highlights a concern for you. So we want to look at building resilience in caregivers, and this can also benefit adults as well, but we want to highlight caregivers as well because we know the parental support, that correlation between elevated mental health in parents and the impact on children is pretty high. So for those of you that do have young kids, you are the model for how your kids manage their mental health and may be able to prevent some issues from starting. So seek your own therapy and support. Like I said in the previous slide, you want to address your own anxiety, your fears, your stress, whether it's associated with PCD or not. We are less triggered by stressors in life when we've already named and processed them, and we're also less reactive to our children when we're coping well. Think of therapy as a gym membership for emotional and mental health. So there's still so much stigma and bias when it comes to mental health. We promote physical well-being in our culture. We talk about going to the gym every day after work. It's not a big deal, but we don't seem to prioritize our mental health in the same way. Like I said, don't wait for a crisis. So don't wait until you're drowning to learn how to swim. You can learn coping skills to manage and maintain your stability to better handle high stress moments. Learn research-based parenting strategies and understand child-teen development. So there are experts in this field of work. So reach out to the experts. There's so much more research that we have now than what our parents had. So utilize that. And then reparenting, what does this mean? So having kids will inevitably trigger the unresolved issues you may have from your own childhood or with your own parents or how they responded to mental health. So therapy is a place you can process those unresolved issues and change some cycles if needed. So since we work with the pediatric population, we want to include information on building resilience with kids. So the first thing, just talk about PCD. Don't hide PCD from your child. We often do want to shield or protect our kids from hard topics, and this tends to create more uncertainty and fear. So talking openly about the hard parts actually demystifies them. It creates an environment where these topics are safe and they're normal. So give your kids opportunities to talk about PCD and answer those questions. Encourage openness with PCD. I think this is actually a really important one. So avoiding or hiding PCD tends to foster more shame, more embarrassment, and a lack of confidence in kids. Kids that feel supported in their PCD amongst peers tend to do better managing their care versus those that are embarrassed or avoid treatments when with friends or suppress their cough in class because they don't want to be different, right? I think it's helpful to ask your child if they're embarrassed to do something in front of friends, like what would you tell a friend? More often than not, it really lessens their fear of judgment. It normalizes that everyone has certain insecurities. Everyone has unique ways to care for their body. And we want to normalize those differences. Teach emotion regulation and coping. So emotional suppression is not emotion regulation. We want to help kids identify their feelings and express them. Acknowledge and validate emotions actually helps build that regulation and the coping skills they need. So name it to tame it. It's a great strategy here. So verbally naming emotions, it calms the nervous system because it engages that prefrontal cortex, which is responsible for our executive functioning, our regulation. So this can sound like you're frustrated with all of this. You're allowed to feel that way. I would too. We don't need to fix our feelings. We need to tolerate them. And teaching kids that is really important. Give opportunities to master fears. So try not to avoid the new or fearful situations when your child is ready. So like sleepovers, summer camps, doing treatments out in public, going on a girls' weekend or a work trip. When we avoid new or fearful situations, it kind of affirms to others that we should be scared of this or you should be embarrassed of this. We really want to tolerate that distress with connection and validation rather than fixing or rescuing. So kids can build their distress tolerance skills and their resilience to face adversity when they have opportunities like this. And just because something is uncomfortable or fearful doesn't mean it's wrong. It means it's new and it's overwhelming, and we need to build some new skills and teach our kids that they can do hard things. And then play and connection. So young children will not come home from school or daycare and say they had a hard day and they need to talk, right? They'll say, can you play with me? Play is regulating, it's stabilizing for kids. This is where they laugh, connect, and release stress. For older kids, for teens, even young adults, creating connection, finding time to do fun things together, understanding the importance of peers during those stages. And if you can, finding a PCD role model or mentor to increase connection around PCD instead of the isolation that may come with this. So we are going to call on all of you now. We're hoping you can put in the chat box if you're able to. What has helped you find success in coping with PCD? And how you manage and cope with this, kind of the psychosocial aspects of PCD. What's worked for you in finding acceptance with the diagnosis and being open about PCD, getting support from family or friends or coworkers, feeling confident, overcoming the stigma you might feel, or cough suppression when you're in public. You really are the experts here. So we'd love to hear if people have any comments or would be willing to put something in the chat that has worked for them. Like, what have we missed and not said so far?
So I see here in the chat that Mary speaks to if medications that you're taking for your PCD also may affect your mental health, like how albuterol gives you headaches, stomach aches, higher heart rate, how that affects you. Suzanne responds that taking fluoroquinolone, she feels often more depressed feelings during that, and managing that piece. And then Myrona also comments that there is a long wait to see a therapist right now since COVID. And before getting that appointment, what can you do before you're able to engage with a therapist or getting in that appointment with the resources you have available?
Yeah, that's such a good question because there's long waits here as well in our state. And And so I think we're going to actually get to that a little bit in some wellness
good.
factors and protective factors to work on.
Marina, you teed up the next slide.
You did. You did.
And
But-
I would say medication wise, you know, we are still learning. Your physicians are still learning about side effects related to medications. That's on some ways, we sometimes feel defensive about that, but we have to be humble about the fact that people have unique responses to medications and that there is such a range of metabolism and sensitivity to medications. And so, yes, validating feelings and thoughts that you're having on certain medicines, I think is really important. Sometimes there are some medicines, if you speak to your physician about it, I know we've had some instances in clinic where we've said, let's see how you feel off of that medicine. We have a controlled situation where we think they're in their best health and stability, where we're going to see how they respond to that change under close monitoring from a doctor, and whether or not it seemed like it correlated more just time-wise in the life and it wasn't related to the medication. Or for kids, for example, sometimes I'll recommend doing treatments, and this applies to adults as well. But, you know, we are our worst mentally, I find, and Tammy, let me know if you disagree, the more sleep deprived we are and the later at night we're doing treatments. And so looking at, can we move the quote unquote evening treatment to sort of an afternoon time, or are we going to make our albuterol a little different in the evening? And so talking about strategies for that with your team may also be helpful.
I think, and bringing up all those side effects, so your team really understands the full scope of everything you're managing and dealing with and can help you problem solve. So if it's a medication that's really needed, that's not one you can maybe trial off, or not one that you can find something different, you need to figure out, how do we create more skills to cope with the additional feelings that you have, right? So that you're not just tolerating it, or you don't feel like you're just suffering through it, that you're trying to be proactive and talk with your team about how to
And have a plan.
I think those medication side effects and just the correlation with increasing things in mental health is very real, needs to be talked about. So if you have other things, please throw them in the chat. We would love to hear from you on things that have worked for you. But going into then some of the wellness and protective factors that we often all know about, but don't always do very well. So don't forget these things, right? So just sleep is huge. It's the top of the list. I think it's the most important thing when it comes to our mental and physical health. So for kids, 9 to 12 hours a night, teenagers, 8 to 10 hours a night, adults, 7 or more. I don't know how many adults are getting 7 or more, but that is really the evidence-based recommendation. It improves memory, cognition, learning, behavior. I mean, it's such a big deal. Exercise, again, a natural mood booster. The benefits include improved thinking. It reduces the risk of depression and anxiety. It helps you sleep better too. So those come hand in hand there. So for adults, 20-ish minutes a day, try to think of it that way, 150 minutes a week. Kids are kind of exercising all the time. Teens and school-age children should be about 60 minutes a day. But that is very important. Time in nature. So 15 minutes a day can result in decreased stress and increased anxiety recovery. So get outside, very important. Mindfulness and deep breathing. There's so many now evidence-based strategies for this that reduce stress, increase emotion regulation, and it's utilized in classrooms more now, which I think is great. And there's a ton of apps that you can put on your phone, whether free or paid, that you can do this throughout the day and little whatever time increments work for you. But this is an evidence-based treatment that we know reduces stress and anxiety. Healthy diet, it impacts mood, energy, alertness. I'm not going to spend a lot of time on that, but just thinking about how that's fitting into your routine. And peer connection, we're wired to be in relationship, to feel seen, supported. Fun activities make us feel better. So fun family time, traditions, going out with friends, those social engagements that are uplifting, saying no to the things that aren't. Social media, there's a strong correlation here between social media and increased anxiety and depression and self-harm in kids. So this is an important one to talk about. It can be real harmful for kids' social emotional development and self-esteem. And this one's hard because all kids, I feel, have phones, and the pressure to fit in, the fear of missing out is really real. But we do have more research and data now that speaks to this harmful impact. So as parents, if we can try to all just join together to try to turn the tide on how we're utilizing this. If you do have kids on social media, just help them think critically about what they're viewing and seeing. I'm loving the social media breaks I see a lot of adults taking. I think that's important. Look at when social media is benefiting you, track your mood before or after, what groups create stress and anxiety for you, and what actually adds to your well-being. Caring and supportive relationships. We've touched on this a little, but a stable and supportive parent or caregiver is the single most important factor for kids to develop resilience. And then regular medical and mental health care. So advocate for yourself, like we talked about earlier, to seek that regular care for your own well-being. Really ask to discuss this stuff, the mental health stuff, the impact of the PCD care on your emotional wellness with your provider. So if you have providers that don't have a social worker psychologist on the team, make sure you're asking about this to prioritize your mental health. And this kind of segues nicely into what Dr. Griffiths is going to talk about next, just how we integrate this within our team.
So step one is we plan. We're fortunate at Children's Minnesota that we have Tammy. We have a licensed social worker on staff who is skilled in therapy. She's also skilled in screening for anxiety and depression, does some of the management of that with our patients, and then also refers to, when it's more practical. We are a 5-state-based referral center, so sometimes she's referring out to providers who are more convenient for the families. But I'll say our approach is to talk about it if we can at our first visit of diagnosis. And that is not to say that everyone with PCD is going to have a mental health diagnosis, but it is to say that everyone with a chronic disease at some point may have bumps in the road where they are not expecting how they're going to manage that from a mental health standpoint. And so having preventative, proactive plans, learning specific strategies and skills with a therapist who manages patients or sees patients who have really complex schedules, who have to do daily treatments, who have to do schedule organization, who have to kind of go through that process of trying to figure out how everything fits in the day, who deal with elements of grief and celebration in their care. I think the earlier you can plug in with the therapist, the sooner you can plan for if stuff falls off the cliff, because we know whether you have a chronic illness or not, or a chronic condition or not, everybody has stressors in their life that are unexpected and unplanned. And so having a skill set already built in for how you manage those events, those big events in life, I think are really helpful, as well as the day-to-day. Essentially, rather than waiting to find out you need some help, it's so much more helpful to build tracks of therapeutic thought when you're doing it proactively. And so we try to talk to parents in our clinic about, your child has our new diagnosis, welcome to clinic, looking forward to seeing you again in the near future. And we want you to start thinking about yourselves as caregivers, plugging in early to learn skill sets that just may not be a part of what you just sort of organically came with to clinic. And so I think that's something that we really try to highlight, that proactive skill building. We also screen our patients at visits for anxiety and depression. They fill out questionnaires. We do this with school-age children, and we do this with young adults in our clinic. We follow patients in their 20s. We follow patients who are infants. And the enemy of good is perfection. And I think that's really important to tell your lung doctor, tell your ENT, tell your physio. Really, if we're always aiming for perfection, we're going to disappoint ourselves. We cannot get every single therapy done on time. We cannot do our best huff cough, our best airway clearance with every element. We have weddings, we have birthdays, we have bad days, good days. And so focusing on what are our wins and where are we winning, celebrating those, highlighting those, and then trying to expand on those is, I think, a healthier approach to kind of avoid our shame and our guilt and our disappointment over sort of that perfection piece. And so when your doc asks you, how many times a week are you doing the things I prescribe? We have to sort of think about how we're framing that question and then how we're framing our response. So we plan, we have someone that really involved in our clinic events and in our appointments. And that's how we've been able to make that work best at Children's. We do multidisciplinary rounds. Our team speaks on a monthly basis to review upcoming procedures, upcoming hospitalizations, post-hospitalization, make sure that we're connecting with our families and our patients and caregivers so that they feel supported by our team. We reach out if we haven't heard from you. because we worried and we care. So that's another thing. If you're getting a note from your doc, like we think about you at home and we're thinking, I really want to make sure I know how Tammy's doing. I haven't seen her in a while. Again, that annual screening I think is really important because patients don't, young children aren't necessarily going to tell you or be able to verbalize or process that something is more cognitive based than kind of that sort of anatomy based. And then also from a physician standpoint, if your physician is passionate about mental health, they are thinking about how symptoms that we feel, true organic physical symptoms, can be manifestations of our hormones and chemicals in our brain being off, and the relationship of those receptors through the rest of our body, how we feel pain, how sleep is disrupted, those sorts of things. So we really do try to assess mental health and need for additional support during every visit here at Children's Minnesota Clinic. So I'm going to pause, but I do want to pull in the chat. There were some pretty awesome comments that I thought would be helpful to just share. I'm so excited that you guys weighed in. I hope you all have had a chance to read these so that if they are helpful to you, you've got additional sort of touch points here. What I see is that that diagnosis is really important, and then finding support from there and getting a good team has been really important in terms of how they respond. And then as a parent with kiddos with PCD, peer support has been helpful. Talking to other PCD parents, sharing what tips have worked for them is really helpful. And engaging other family members in the care. So it's not just the primary caregiver, I think is smart. Mary acknowledges that not everyone approaches it the same. She and her sister handle it differently. And that is also very natural. And I like that you're pointing out kind of that difference of personality and where one needs to fill their cup for additional support. And then Susie talks about how it's changed the family, also in a positive way, but also becoming focused on health issues in a way that you weren't before, ever since diagnosis now. Grandparents struggling, where there's an exacerbation, yes. Sometimes other family members have a lot of fear. Sometimes we see grandparents sort of respond with really big emotions around it when the parents see the day-to-day and they feel differently about it, and trying to kind of bring them on board a little bit, but also validate that their feelings are coming from a place, hopefully, of love, and what the new normal is. And I think grieving a sense of what normal you wanted normal to be versus what new normal is something I see, particularly in late diagnosis, when life went one way and then all of a sudden new diagnosis, we're changing your day-to-day activities, and it can be pretty major for these kids and adults.
Expectations.
Mary talks about moving that time of her treatments. Awesome. I'm glad that was helpful for you, because it does sometimes help people fall asleep earlier if they're not jittery with their albuterol right before they're trying to lay down. And I'm so glad Stephanie has found this meeting today to be helpful to connect with other families and physicians and validate what you're going through. Esther mentions that making all of the things that are prescribed a part of the normal day routine is helpful. We do try to take that approach, particularly with the younger children. The sooner it is normalized that, yep, I expect you to wear pants when you leave the house today, and we are also finishing your hypertonic saline. I do find that helpful, particularly in the youngest of children, because you start to build routine a lot better that way. The older they get, the more they start to notice, hey, yeah, my friends wear pants, but they're not doing hypertonic saline. And validating that normalization, that looks different, is a good thing. The UK PCD support team talks about connecting with other people in a positive way, and chat groups. Peer support is good. The only thing I really caution is sometimes we find in social media kind of a slant to the negative, because oftentimes it's a place where people are coming in crisis or a complication. And it's really hard for someone to respond to that with, I don't know, my kid's doing awesome, or here are the things that are going so well in our household. And so sometimes it becomes some gloom and doom silo. It can be a good resource for information and to reach out, but you have to be really purposeful for how you're editing and that sort of experience, I think.
Especially if you find it's kind of eliciting more fear and worry in you of like what may be to come,
Is
right?
there
It
more
might not be
stress?
your story. That person's story might not be yours, but you might
And PCD
feel more anxiety about it when you
is
see
just
it,
not homogenous. It is not a uniform experience, right? So glad that was helpful. And then Emily, art therapy, I love this. And I love that I also saw someone mention that their child likes to draw themselves in therapies. And lots of parents teaching their children that PCD is their superpower. We have families in clinic who talk about your super special lungs or your super powered lungs. So we do hear that a lot and love to hear that. And then I see here Natalie acknowledging how hard it can be to hide cough at work or on dates. And then learning that cough is therapeutic, learning that cough is that helper to move things on is so important, but also really normal in this COVID period of time. You know, everybody stares at you if you cough, or in, you know, class for the kids. And how can we make sure we're normalizing those behaviors? So, there's just a lot of great comments here. Two more. Gaia said, I apologize. I'm certain I said that wrong. In Norway, patients saying they couldn't get a referral to mental health services due to the PCD diagnosis alone, but had to get an anxiety diagnosis from their GP.
Right.
Yeah, it's super frustrating what you can code for and what you can't to try to get that approval. And we share those frustrations. Sometimes adjustment disorder to a chronic condition is something our therapists use. And it's something to kind of think about and partner. Ask your center who helps look at these problems, advocate for yourself and advocate for other patients in your group, and say, hey, I'm not sure if my worries lately have been something that are normative or beyond normal and need more intervention. Have you thought about adding screenings to our center, to our clinic?
Right.
Who do you refer to? They
Right.
may say no, they may say, I don't know how to do that. I'm not familiar with that. But the only way they become familiar is if it's really something that becomes a focus. So I think it's good to ask your centers, what are they thinking about rolling out in that area? More often than not, it's in the back of their minds. And sometimes that last push is what helps make a center really prioritize and think about how important this is to PCD health. Sarah talked about books for kids. Yes, we've had some books on mucus and snot and things like that. And I do think that is something that can be helpful. Therapy, singing and choir, love it. Airway clearance, and also brings joy. Italian groups working on this. Yay, Italy, ages 5 to 6 to 10 years. We dig that. You're on our team here. In Cyprus, patients get free sessions with a psychologist who specializes in chronic disorders. Yay. And there's a referral made from there. And Michelle Mannion talks about here in the United States and North America, one of the books that we have, and would love to kind of share ideas and gain more from you guys. So thank you. I'm going to pause and open up for questions. Thanks for listening to us. And we hope that some of this has been useful. If nothing else, I always feel like the chat with other patients and families is truly invaluable. So thanks, guys.
Thank you very much for that lovely introduction. So I am Amanda from Southampton, and thank you for inviting me here to talk to you about transition today. So what is transition and why is it important? So transition's got many meanings. Okay, my slideshow isn't moving. There we go. In this context, it's about preparing children to go to adult services. It's more of it's an education program really to teach and empower children to have the knowledge and skills that they need for going into adult services. It's a process that includes their medical needs, their psychosocial needs, and their educational and vocational needs. And it very much puts the child as an individual in the centre of the programme. So thinking about vocational needs, for example, we address this quite early in the process. If you have PCD, there aren't many jobs that you can't do, but one in particular is joining the forces, so the Army, the Navy, the Air Force, and where I live, that's a very common thing for kids to want to do. So we would rather very early on tell them that they can't do that, so that they can work with their parents and their schools to redirect them and find something that they can do, that they would like to do. What it isn't is a transfer. So many people mix up the word transition with transfer. Transfer is a single event of moving from paediatric services to adult services. So you get discharged from your children's positions and moved across into adult services. Transition is a much longer process. In the UK, we start at about 11 or 12, which sounds early, but I'll explain that a bit more in a moment. And it's a very slow process to drip feed in bite-sized pieces all the knowledge and skills that kids need before they move to adult services. So why is it important? Well, when you're small, you're in clinic and you're playing in the corner, and the doctors and the nurses and the physios, everybody speaks to the parents, and that's fine. You're playing in the corner, you'll take some of it in, but it's not really you that gets involved in the conversation. And that's quite easy to keep up as a habit. Even when doctors and nurses try to involve kids when they become adolescents, they don't really want to get involved. They might be playing on their phone, staring at the ceiling tiles, daydreaming, but they're not really getting involved. And then they get to adult services when they're not with their parents. And what we were finding, not in just PCD, but in all disease groups, that when kids went to adult services, they either didn't bother to go to hospital appointments anymore. Their mum and dad used to make them, but now they're adults, they just don't need to go and they don't see the value in it, or they don't carry on with their treatments, or everything else in the world is much more important than their PCD, so they don't go and pick up their drugs, and then they all fall in a heap and they don't do so well when in early adulthood. So we had to find a way of addressing that, and that is transition. So if you have a good transition, it should empower young people and give them the knowledge and skills that they need to manage their condition. It should reduce the risk to being lost to follow-up by helping them to value their experience with the hospitals and make them want to come back and continue to be monitored. And it does improve their chances of staying well in young adulthood. To be honest, we don't have that evidence in PCD specifically because we haven't done the research, but in any other disease group where it has been investigated, children do much better, or so I should say young adults do a lot better with a chronic condition if they've gone through a transition process and they understand why they need to do the treatments that they do. So thinking about that, we had one of my colleagues, Steph Harper, did a piece of research recently. That's not true, it wasn't a piece of research. She had a parent group for cystic fibrosis adults. They hadn't been using a transition program, and these particular kids had got to about 14 or 15, and she wanted to talk to the parents to explain to them what transition was and to find out what their feelings were about transition. And she generated this word cloud, which, as you can see, has quite a lot of negative words in it. Parents were worried that their children wouldn't have the skills to be able to manage themselves when they went into adulthood. They were worried that the clinical team were trying to take control away from the parents and exclude them from their care, from their children's care. They were worried that they wouldn't manage admissions, that they weren't ready, that they wouldn't understand well enough to be able to manage their own health going into adulthood. My thoughts on this is because 14 to 15 is too late to start this stuff. by then it's a real concept to parents. When we start at 11 or 12, the parents know that the children are not going to adult services for at least 6 or 7 years, so they don't have those same concerns. They understand that it's an educational process, and in the same way that you send your kids to school to learn to be independent, successful adults, this is just the same thing. It's just an educational process to give your young person the skills and knowledge to be able to make good decisions about their health. The other thing about starting young is if kids have already gone into puberty, they're not really interested in this, where if we start just before they go into puberty, they've got used to engaging with the process, and it's just something that they continue through puberty. And if you start early enough, they're actually interested. At 11 or 12, they want to tell you what they know. They're quite happy to admit what they don't know. That's harder as you go through adolescence. So starting the process early and making them feel like they're in the centre of their own care can really help with those conversations. So I'm going to talk about the Ready Steady Go programme because that's what I know, that's what I'm part of. But there are lots of different other different transition programmes that you can use. I'm hoping this is going to work. I'm going to try and click on the website. Can you see the website? Does that come up for you guys? Brilliant. Okay, so this is a free website that you can go to and download the questionnaires. You can look at it as parents or professionals can use it. It's, as I said, this programme started off in Southampton, but very quickly it went national and then international. And with the help actually of the BEAT-PCD group, we've managed to translate these tools into all these different languages, and there are further translations that are occurring at the moment. So if I show it to you a bit, it's a traffic light system. So we've got red, amber, green, ready, steady, go. And we start off with a questionnaire. It covers all aspects of daily life, from knowledge about your condition, sticking up for yourself, smoking, drugs, healthy eating, good exercise, looking after yourself, your schooling and your future, and mental health. And we work our way through this. This is obviously a really long questionnaire, and you couldn't do the whole thing in one appointment. We sort of spend about what the child needs, but probably about 5 or 10 minutes in each consultation, and we move through the programme. So we start off at 11 or 12 with I can describe my condition. So if I was doing this with a child, I would say, so why do you come to hospital to see us? And sometimes they'll say, because my mum makes me. But if you delve a bit deeper, then they might say, because I've got PCD. Brilliant. What is PCD? It's primary ciliary dyskinesia. Oh, that's a lot of long words. What does that mean to you? What is PCD for you? And we slowly talk through it and they describe what it is. And then by the time they're 17, 18, ready to go to adult services, we've moved to, I am confident in my knowledge about my condition and its management. And at that stage, I'd expect them to know a bit about mucociliary clearance. I'd expect them to know why they need to clear their lungs of the bugs and the mucus that are in their chest, and what was the purpose of having mucus in your chest, and be able to break down what all of their treatments and therapies are, and know why they need to do them. But I'd also want them to be able to have learned the skills to be honest, and to be able to say, actually, I just can't be bothered. I haven't done my physiotherapy in the last couple of weeks, so that we can talk to them about that and try and work out what the barriers are. I've spent an awful lot of time making sure that the young person realizes that it's them that's important. They're the most important thing. They have PCD, and that's a small part of them, and we have to deal with that and work out strategies to manage that. But what's important is them. The other thing we do to do that is we use, we talk about shared decision making really, really early on, and we use this concept of ask 3 questions. We find that kids are more likely to follow a regime if it means something to them, and if we've put them in the center of it. So 11 or 12, we might be asking them to make really simple choices, like, am I going to take tablets or have a liquid, a medicine? But as they move along through the process, these will be more complex questions. And we get them to frame these decisions using these 3 questions. Making a decision is a really, really difficult thing to do. It's a skill. And as a child, you don't make many decisions. Your parents make the decisions. It feels like the doctors and nurses are telling you what to do and everything's happening to you, giving you some empowerment so you feel like you can shape things can really, really help and make it easier for adherence. That question about adherence earlier on, we quite often hear that parents and their children are really, really fighting about getting their physio done, say, before school in the morning. And that the fighting takes much longer than the actual treatment would. So we talk to the children about that and try to get them to come up with strategies. I've got one child who she put a blackboard on her door and she ticks the blackboard to say she's done her treatments. How old is she? She's probably mid-teens, but because they were fighting so much, this was a way that she had some empowerment. She could say that she was doing her treatment, and if she hadn't told her mum that she was doing her treatment, then her mum could nag her, but that was her decision because she'd chosen not to do her treatment, not to tick the board, so then her mum was allowed to nag her, and that they worked through that together. So for each question, what are my choices? Should I start smoking? Should I not start smoking? Should I have this operation? Should I not have this operation? Should I train to be a doctor? Should I not train to be a doctor? Whatever the 2 choices are. And then what are good and bad about each choice? You explore that with the young person and get them to come up with their own ideas, but you can add to that a bit or get their parents to help as well. And how do I get support? Who can help me make this decision? And generally that tends to be peers, parents, professionals. And often I direct the young people to the patient organisations, the charities, so that they can go there and have a look for information about that themselves. For educational stuff, that might be schools. And together we come up with a plan. Okay, so that was the Ready Steady Go website, and here is the where you find Ask 3 Questions. But all of this is translated on the website. So by the time they get through to adult services, we aim to make these kids experts in their own care. This is important in any chronic condition, but PCD, as you know, is really rare. They're often going to encounter doctors that have never heard of PCD, so they need to understand their management plan. They need to know, when my cough is worse, I need to give a sputum sample so that we can look for bacteria to make sure I'm on the right antibiotic. They need to understand all of that. They need to understand the length of the course of antibiotic they need, which antibiotic at the moment works best for them, but understanding how it might change. They need to understand more and more of patients in the UK, I don't know if this is worldwide, but they have their own personal lung function machines at home. If they're going to be doing their own lung function, they need to understand what they're looking at. They need to be confident in managing their condition. And they need to feel able to contact their healthcare professionals. Again, that's a skill. You need to learn to ask your own questions. It's not just picking up the phone. It's quite a big deal to phone someone and say, I don't feel very well, can you help me? It is a skill. And in fact, when we bring up our children to be polite, whenever you say, hello, how are you? They say, I'm fine, thank you. It's a big step to go from I'm fine, thank you to actually I'm not fine and I need some help. And we need to get them practicing that, which is why starting from 11 is so important. If you start practicing that early, it should be easier when you get to adult services. And then ordering their medication, they need to be able to do that. There's many other things they need to be able to do, but this is just some examples. And I forgot, I was going to talk about an example about exercise. I had a young lad who we were struggling to get him to do physio, and so we were trying to encourage more exercise, so at least he was doing something. And I asked him what was the most important thing about exercise, and he said it was to clear his lungs. And I said, no, that's not the most important thing. Think again. And he said, so that I can lose weight. And I said, no, not the most important thing. So what is the most important thing? He couldn't think of it. And when I said it's for enjoyment, it's something that you enjoy, that makes you feel great, he was like, really? And then he was much more engaged, and he's taken up skating. That's his thing. He's decided to take up skating, which is great for him. When we were trying to get him to run, we signed him up for park run. We were trying to get him swimming. He didn't do any of that. But once it was his thing and it was primarily for enjoyment, he's now doing that well. So we've given them the skills, but they don't have a written plan of care at this point. So we need to get something that's universal for PCD. Everything I've spoken to at the moment has been generic. It could have been used for any health condition, but PCD is rare. So we want some kind of generic document that they can take with them to adult services. So BEAT-PCD asked a group of us to come up with a transfer document, as I said, specific to PCD. It's kind of a standardized checklist that goes with them. The patients can have a copy and it can be sent with a referral letter to their to the adult physician that will be looking after them. This allows for a choice of transition program. It doesn't have to be ready, steady, go. And it ensures that it's patient-centered information. It's not about teaching about PCD, it's about the person that we're talking about and how PCD affects them and their treatments. Excuse me. It will include their diagnostic information, as people have spoken about today. We hope that there'll be treatments going forward for PCD, and it's really important that we know what kind of PCD you have, what's your genetic diagnosis. If you don't have a genetic diagnosis, what are your other test results, so that your physician can see whether you're suitable for upcoming treatments. Also to include clinical investigations that you may have had prior to transfer. So you may have just had a chest CT or a sinus CT. As somebody said earlier, you don't want loads of radiation. So if the clinician knows that you've recently had a CT scan, they can write to your paediatric centre to get those test results to save you from having to have them done twice. List your medications and treatments for your record as well as for your adult team's records. It talks about any communication issues. So throughout the pandemic, anybody with hearing loss has really struggled with masks. If we've noted it down on a transfer document, it might be that the adult team, depending on their infection control policies in their hospital, can either remove their mask to aid lip reading or use one of those clear masks where you can see lips a bit better. We can also talk, I've seen in the chat you've been talking about autism and ADHD. We can also note down anything there so that the new team are aware of any communication issues you might have. This group that's creating this document is made up of paediatric or children's nurses, doctors, physiotherapists, adults, nurses, doctors, physiotherapists, audiologists. We have ENT consultation, and there's a parent and a patient, a young adult patient that's involved in this process as well, because we want to try and get it all right. And as part of that, we decided that there should also be an all about me section that the patient themselves could fill in. And we have not finalised this. We're at the very early stages of this, but we were thinking about something like this, so I thought I'd show you. So we've got sections, obvious things about what you'd like to be called, not just what your given name is, what your hobbies are, what your plans are for the future, where you live. But most importantly for the patients in our group at least is hopes and expectations, concerns, your worries about going to adult care. You could write here if you wanted your parents to attend with you, things that you want the adult team to know about you, and questions that you would like to ask the adult team. So in summary, transition is an educational process to equip young people with the knowledge and skills to manage their condition. Transfer is a single event of moving to adult services, and a good transition and transfer is essential to give young people the best chance of managing their conditions well into early adulthood. And that's it.